Thank you. And I was also very pleased to have Claire Wakefield mention Andrea Patenode, who was an absolutely wonderful colleague of mine. She was a hands-on clinician. She was also a pioneer in the area of looking at psychosocial implications in LFS, as well as other hereditary cancer syndromes, and a collaborator with people around the world. So she is definitely missed. And definitely informed my genetic counseling practice. So I'm going to talk about some of the current genetic counseling dilemmas. There are obviously the ones we always have, dealing with families and explaining very complicated concepts and dealing with people at kind of difficult times in their journey. But some recent complexities with genetic testing results, I think, have added a layer to this. So what I'm planning to do is very briefly describe kind of 5 case examples of situations that have come up and some questions that have arisen and ways that, and the different impact of this from the pre-test counseling to the post-test questions about how to manage this. So the first case represents a woman that we met who is 30. She had been tested before she came to our center. She had breast cancer at 29, which we would all agree is an age where we might see a TP53 mutation, and one was identified, but only at a low percentage of cells, and this was identified in 28% of her cells. We did not have a chance to test her parents or to confirm it in a different specimen, so the question always remains whether this is really germline or somatic, but going with the presumption that it could be germline, the questions she had a lot were really pertaining to her daughter and the risks to her daughter, and were those 50% risks that we quote in regular LFS families really relevant, and what then should she say to other family members as well as her risks going forward. The second case is a woman who also had early onset breast cancer, because that is a lot of our practice, and she was 36, so she was 10 years out from her breast cancer. She was found to have a TP53 mutation. It is considered to be one of the lower penetrance mutations, although you could argue she had young breast cancer. However, when we tested her parents, we were kind of surprised to see that it was identified in her unaffected mother, who is now 64 without a cancer diagnosis. There are other individuals in this family that I'm not showing, but also are cancer-free at somewhat older ages. And so the question is, how do we then provide information to the rest of the family, and how do we think about this? Do we think about this in a different way than when we're presented with a classic LFS family? And as Dr. Garber mentioned yesterday, families can be low penetrance until they're not. So that's always something in the back of our mind. This is a case that we've actually brought up before. It's a woman with a sarcoma and a breast cancer, so someone that, again, we wouldn't be surprised to see a TP53 mutation. The rest of her family did have cancer on both sides, but not to an impressive degree in terms of Li-Fraumeni syndrome risk. We did find a TP53 mutation in this woman. We also found a BRCA1 mutation, and we actually have multiple cases now in the adult world where we have identified either one high risk and one moderate risk gene, 2 moderate risk genes, even 2 high risk genes. And in this particular family, one of the questions that has arisen, obviously, we would talk about the LFS risks, we would talk about the BRCA1 risks. What about the cancers that sort of overlap, the breast cancer risk, and how is that increased based on having 2 different risk factors or is it increased based on that? She has a sister who didn't have either mutation. Does that mean she's off the hook in terms of the family history risk? And then we have another one who has the BRCA mutation and not the TP53 mutation. So again, I think as we're learning about this, it goes beyond just looking at one gene and one set of risks. Another case that we've had is we have a situation where the person who was initially tested is a woman with breast cancer at age 32. She was identified to have a TP53 variant that was considered a quote-unquote likely pathogenic variant, and this means that there was preliminary evidence that suggested it probably was going to end up being a pathogenic variant or a mutation, and we tend to treat those in a similar way clinically to people with the pathogenic or mutation results. We went ahead, tested her siblings, tested her daughter, who turned out to carry the TP53 variant, and then this was in 2016, and then a year later we received the lab report saying, it has been downgraded to a variant of uncertain significance. Now, if this initial woman had been tested and the result was a variant of uncertain significance or VUS result from the beginning, we would not have tested other family members, and we probably would not have recommended enhanced screening, because the majority of those results turn out to be benign or normal DNA variant results. But now we're in a situation where we started off with it being a likely pathogenic result, and the question is whether we need to continue doing that. You can imagine the difficulty of explaining this, because a VUS result is not a normal result. We're not saying that there's no chance that it could then turn around and be upgraded again. Makes it very challenging. And then the last case example is a situation where, I think especially in the United States, where family members tend to be scattered throughout the United States and elsewhere, is that you can end up with a situation where different family members are tested for the same gene but through different laboratories, and different laboratories sometimes will provide conflicting interpretations of what the result means. And this is an individual who had a brain tumor at 38 and CML at 47, was found to have a TP53 variant. The lab that we used did call it a VUS, or uncertain significance, and yet when we looked it up in ClinVar, and subsequently other relatives came in with their results, where there was a huge range, where one lab called it likely pathogenic, another called it likely benign. So again, what do we do with this result now that we know it, and what do we recommend? And then the genetic counseling issues that have come up, I think what we're seeing is that we're shifting from providing a lot of information about potential gene risk at the pre-test counseling session, and we have adopted the use of these multi-gene panel tests. We tend to pick and choose because there's really no way to provide adequate information about 46 or 80 genes that are on a particular panel. And what this has resulted in is that a lot of the counseling then occurs at the back end of the testing process. And we also tend to rely heavily on the family history information, not just utilizing the recommendations for people with LFS, but if there are additional cancer risks in the family, we want to make sure to include them. However, now that we're seeing ranges of family history information, we're relying heavily on the molecular results as well. Cancer risk estimates, there certainly seem to be some families where the risks tend to be lower than 90%, others where it really does seem to be the very striking high results. And is there a way that we can somehow provide more personalized cancer risk estimates or estimates based on the age and organ specific? And these are certainly things that families and patients have been requesting from us. My hope was that the more people that had TP53 testing, the clearer the results would be, and yet it seems as though that has not been the case. We're expanding the phenotype rather than crystallizing it. And in terms of medical management, any of the case examples that I provided, are there certain scenarios or situations where we would consider altering the recommendations that we are given, and kind of what would be the thought process that goes into that. Right now, we do tend to take things on a little bit of a case-by-case basis in addition to using published guideline data. But as we go forward, is there a way that we can thoughtfully consider that? And then as individuals have testing and go through the process, I think one of the things we heard loud and clear at this is that patients and families want to know what to do next, whether they are newly diagnosed, whether they found out about this TP53 result 10 years ago. The question remains, what are the best steps that I can do to take care of myself, and what screening regimen should I follow? And that when there's a complex TP53 result, I think that just muddies the waters and it makes it really complicated to know kind of what category to put people in, and in terms of what recommendations to provide. In terms of offering cancer risk information to offspring and other relatives, again, this can be challenging. One of the situations that can happen when you have a complex result, for example, a mosaic result, one option is to test the parents to see if that might help with the information. It can also help with one of these low penetrant mutations to figure out which side of the family might have this. And so sometimes that can help clarify things. So sometimes we have provided information about the result, but saying more family testing might change how we're looking at this or thinking about this. And then other situations that have come up where, again, as a practice, we don't usually recommend testing to people with variant results, VUS results, because the high likelihood is that's not going to have clinical significance. However, there are exceptions to that. And how do we think about providing information to relatives if and when that happens? And then the final remarks are just that the emerging data tell us that there's more to learn about Li-Fraumeni syndrome. I'm not saying anything new that we don't already know. And how can providers best counsel families about it? And I think it definitely underscores the importance of the consortium and us being able to work together, learn together, pool the information that we're getting about this. And one of the tasks that the LFSA Genetic Counseling Advisory Group has is to create more resources for families and providers, not just for adults, but for teens and for children, and making sure that we have things not only available, but available in different languages for people around the world. Thank you.
Great, thanks very much. That's a beautiful overview of some of these complex issues in genetic counseling. So, any questions? Yeah, Arnie?
I was going to say, I think as we learn more about other genetic markers and environmental effects, those unknowns that you really brought up will need to be factored in. And I guess the question is, what's the transition time for you to factor them in? They go from experimental hypotheses in labs to tested ideas to clinically useful in some quantum steps. And That, I think, is the hard question. When did they become so good, the additional information, that you use it clinically?
I think that's a great question. And, I think we hear something from one group or we read one article and we immediately want to start presenting that information, and yet that can be problematic as well. You want to have a body of literature, there to be some consensus, and I guess I feel very fortunate having the Life Consortium, having the Medical Advisory Board as well, and I really think we need to just keep talking to each other and making sure we're giving consistent messages, because that's something else I think that can be very confusing to families when they have individuals going to different providers or jumping around to different places and getting different information.
I actually think that you could be extremely helpful also to the research community in the following way. You pointed out this family that clearly had Li-Fraumeni syndrome, but the mutation in other families wasn't in fact so severe when it was called unknown significance. And for instance, I'll talk this afternoon about a hypothesis that says that if you knew the HLA types of the two families, that might sort out, in fact, the way in which you could make that decision. Even if that is not a fact right now, it'd be very useful to know the HLA types. Why? Because it would help us do the experiments and look for those kinds of associations.
Absolutely, and I think it will be important to let us know what additional information to collect as we look at more genetic modifiers and environmental modifiers and recognize the great importance of that. Absolutely. Thank you.